Hi, good morning, everybody. So today's CME, I would like to welcome everybody. And today with us, we have Professor Joydeep Chakravarthy from Kolkata. He is a head of the Department of Bone Marrow Transplant and Haematology. And for today's CME, our chairperson is our Professor Do A.G. She is a head of the Department of North Oklahoma Hospital and even for Medical University too. And today we will going to talk about the CAR T cell therapy, which is the new therapy around the world. And Dr. Joydeep Mukherjee has worked in that. So today he's going to talk about CAR T cell therapy, current status and future. So now I welcome Dr. Joydeep Mukherjee. Joydeep Chakravarthy.
So this will be telecasted?
Yeah.
Okay. So thank you very much. It's been an amazing few hours since I landed in Myanmar last night. So thank you very much for this opportunity. So we're going to talk about some B cell malignancies here today. And I, obviously, the audience in front of me are all hematologists, but I hopefully don't have to go down very deep to explain in the basics. So we will assume a level of knowledge on this, and then we will go on. So we're going to talk about immunotherapy in B cell malignancy. Uh, Even online or if you're here, please feel free to stop me anywhere you want and ask questions. So let this be more interactive rather than didactic. So first of all, what is a bone marrow? The whole point of immunotherapy, the whole knowledge of immunotherapy, I think, comes from the early 1950s after the Second World War, when we were seeing marrow aplasia, we were seeing leukemias, and effort was being taken to treat them by doing bone marrow transplantation. So perhaps that is the start of immunotherapy, thinking of immunotherapy, and then we came to know about HLA, Mrs. Teriyaki and Wood, and we came out with solid organ transplantation, and then bone marrow transplantation started to take effect. I had the opportunities to meet a few of those pioneers, and it has been that should be another talk, history of bone marrow transplantation, and it will take us at least a couple of hours to talk on that. But we do bone marrow transplantation when this tissue here is not producing enough cells, as in a plastic, or producing abnormal cells. And one of the reasons we do autologous bone marrow transplant in lymphoma is this is how we do the autologous bone marrow transplant in lymphoma. I always give the analogy that the bone marrow is a garden, and we are works for lymphoma from quite a long till now that is happening. So the reason for this say, overall survival with this. So, is there any way we can improve on that, decrease the morbidity, and improve on the disease-free and overall survival? So, that is the question that we wanted to ask ourselves. And doing that, we tried to look into this. So, this is my alma mater, and when I trained here, we used to do lace transplantation. With lace, what we were seeing was um, that the mucositis wasn't there. So this is, no melphalan substituted by cyclophosphamide. Dose of araci and etoposide goes up. BCNU substituted by lomustine. So with that, we don't get much mucositis, definitely, but the outcomes remains much the same. This is one of the papers again from Hammersmith. And then the overall and progression-free survival are around 56 and 50% for chemosensitive patients, less for chemorefractory. So okay, so this is come in. Sorry, this is not needed. This is not needed. This is a bit of propaganda. You can see this is one of my papers, so no worries. So as I said, there is a little bit of pneumonitis and the outcomes are not very good. Can we improve on that? And we'll just go back to a little bit of history. This is Goodman and Gilman. And when there was an air raid at Bari with nitrogen mustard gas floating in the sea, they started experimenting with that and they came out with a new medicine called Mustin, which was first injected in a patient, and that gave us good amount of relief in the patient itself. So
Professor.
hi. No. So with that, what Goodwin and Gilman started doing at the Yale University was researching on that molecule. And after the First World War, this molecule was taken away by the East Germans, and they added a few rings and came out and subtracted a few rings and came out with a molecule called bendamustine. And after the German or the Berlin Wall fell down, we became aware of this drug called bendamustine, which East Germany was using to treat all their lymphomas, myelomas, everything with. So we became aware of this quite late. And then, the question that came to us is that can we put bendamustine in the conditioning regime of autologous transplant? And this was one of the papers which suggested that you can give and you get a overall survival quite high and the disease-free survival definitely better than what was there previously. And in the long-term follow-up also, we can see an overall survival of almost 80% and the disease-free survival near about 70-75%. So can we evaluate that or can we do a little bit better with that? So this is, we're using bendamustine with beam. So substituting bendamustine and putting bendamustine with etoposide, cytarabine and melphalan. But again, a lot of mucositis happened. So what we did was we came out with a regime called BASE. And this has been published again. And this has worked very well. And what we have found out is that we are getting almost a 75 to 80% disease-free survival with autologous transplant when we use this. And we are also getting overall survival almost reaching 85% with that. So this is something which I think, putting bendamustine in your autologous transplant, as you have done, a few autologous transplant when I'm sure it's going to restart very soon here. This is something you can definitely think of incorporating. So we have done almost 40 patients now, and the outcomes are not very bad. And we forget about CAR T cell for these patients. Patients who can have a transplant, let's do an autologous transplant for them first. If they are failing an autologous transplant, fine. Now we have got something else to provide them with. And that is my immunotherapy, which we will come to next. But before that, let's not forget that an autologous transplant, an age-old procedure, is still holds good for majority of our lymphoma patients. So where do we get the, where, as I said, we get the evidence of the T cells working from our graft versus leukemia effect in allogenic transplant. And once we take the immunosuppression away, we see the GVHD might come along. And along with that, if your chimerism is low post an allogenic transplant, you take immunosuppression away, patient's chimerism start getting better. So those are the things that give us evidence that my graft versus leukemia effect is there. Once we have a chronic GVHD, chances of the patient relapsing is much less. So these are all indirect effects. And we know that if you T deplete a transplant, you take all the T cells away, and then our chances of relapse increases. So that was the problem with the early haploidentical transplant, where we were pan T cell depleting most of the cells. So the only place in the world where they were getting good results were Padua in Italy. Apart from that, nobody else was being able to reproduce those results. So nowadays we are now a little bit more clever, or we hope we are a little bit more clever. Whatever we do, the disease seems to take a step ahead of us. So anyway, so these are some of the evidence, but the most direct evidence comes from giving donor leukocyte infusion. So today I have a patient whom I have done a haplo whose chimerism had fallen down to 80%, an AML girl, 14-year-old girl. So I am giving her DLI, and the last chimerism has come up to 95%. So, DLI works, and that is the most direct evidence that my T cells are going to impact on the disease process. And this is just a picture to corroborate that if I've got T cells, I get very good results. I do get lots of GVHD with it, but my relapse is definitely much less compared to if I T deplete. Why do the syngeneic twin transplants relapse so often? That is because there is no graft versus leukemia effect in syngeneic transplant, or very minimal. So, people came together and thought that if we T cells are working so well, can we not isolate the T cells and use it? And one of the first evidence came from Dr. Ayan is here, is from the melanoma study, where they were using activated T cells to treat melanoma, just to give T cells back. So that was a much more cruder way of doing that. Is there any way to improve it, to get a bit more sophisticated T cell infusion? And that came out with the advent of CAR T cells. So what you do is basically let's just see this slide, that is a little bit better. So you've got the CAR, and then you've got the virus, and this becomes the antibody domain. CAR means chimeric antigen receptor. So it has got two DNAs. So the T cells will have two DNAs. One is the one of its own, and then the other one is this virus which we put in. So this is the retroviral vector that we put in. And that has got two domains, one or two, but it will depend, one or two domains. Along with that, we have got some signaling domains here. So one, maybe, two, maybe three in the third generation CARs, okay? So with that, what we do is we reproduce or grow the cells in the lab, and then we give it back. And once we give it back, these are the T cells which have got the CAR in it, or and these are the domains which are going to act on the tumor cells, and these are the tumor cell antigens is going to act, and with the direct cytotoxicity go and kill that cell. So this is what we call CAR T cell. Again, the similarly way of doing it, the T cell here comes in, the viral vector, and this is going to go and attack the tumor cell here. Now it depends on what the disease is that we treat. These domains that are there, the tumor binding antigen domain, are selected. So if it is a CD19 positive ALL, we select a CD19, let's say, domain on the cell surface. So if it is a lymphoma, we can select a 19 or a 22. I must say, what the trials that are happening in India and CAR T cell presently are with CD19. But we thought that we will talk a little bit different, because the most common hematological malignancy that we encounter in adult hematology is multiple myeloma. And is there a BCMA directed treatment, or a treatment for multiple myeloma? And that comes up that there is an antigen called BCMA. which is expressed on the B cells, and that is responsible for the B cells to change to a plasma cell, and that is when it starts producing its immunoglobulin. So, if that is so, what do we can we target that? So you see, one of the major problems with CAR T cell is that this antigens that we are targeting shouldn't be expressed on the normal cells, especially the normal hematopoietic cells. So this is an issue we are facing with the development of CAR T cells in acute myeloid leukemia, because whatever we are trying to target, the leukemic stem cells, we're seeing a little bit is also expressed in the hematopoietic stem cells, be it CD123, be it 117. So some of them are being expressed. So we are in search of better antigens. And while searching these antigens, in multiple myeloma at least, we find that BCMA is an antigen that which we can target in multiple myeloma. And that is how the CAR T cell story in multiple myeloma started. And what we do, again, this is a much more clearer picture. You're collecting the blood, so you're collecting the lymphocytes here, and then we are isolating the T cells in the lab, and we are activating the T cells with lots of cytokines, and then we are going to put in the CAR T cell vector here, and that will have these two domains here, and that will have some more domains here. One of the major things, or the major, we will come to it. So we'll have some more domains here. We expand that and we give it back. So we've got certain antigens, CD19, CD22, BCMA, CD71 for AML. So if you're looking at the evolution, initially we got one signaling domain to activate the T cells and the only one co-stimulatory domain. So your T cells need co-stimulation. But the first generation CARs were not activating the cytokines that well, and we were not getting that the response for a long time. So they developed a second generation CAR, and if you are talking about all the commercial CARs that are available, we are talking about the second generation CARs, where we have got two co-stimulatory domains, OX40 and a CD28 domain, okay, along with the signaling domain. But now what we are going to try to do is to most probably have, not, so the, sorry, a second generation CAR had either the 28 or the OX40. Whereas now in a third generation CAR, you're going to have both. And let's see, how the third generation CARs are going to come up in clinical trials. But commercially, we are still stuck with the second generation CAR. They're working well for quite a good number of patients. But let's say for lymphoma, we see that around a 40-50% of patients having CAR T cells are relapsing after a year or so. So that is the issue as to how we can develop our CAR T cells a little bit better, so that we can prevent the relapse and the long-term efficacy happens. We have to remember the associated toxicities that we see. One is a cytokine release syndrome, and this can be very bad. And especially it depends on the amount of disease that is on board. Now we have, if you're doing haploidentical transplant with post-transplant cyclo, we do get a lot of CRS also at there. But but thankfully the haplo CRSs get suppressed by the cyclophosphamide we give. So we don't get really grade 4 CRSs with haplos. Very rarely we do, but very rarely. Whereas here the chance of getting a grade 4 CRS is high. It is perhaps little less than if you are giving a bidirectional or a BITE antibody, a T cell engager antibody in a patient with a very high disease load. So, for example, if you give a drug called belantamab to a relapsed ALL patient who has got a lot of blast in the bone marrow, you are prone to get a lot of CRS. So, CAR T cells also we are going to give to that. Maybe the CAR T cell CRS is a little bit less in severity compared to the BLIN CRS, but it's just if it's something is 20, the other is 19, really nothing else. So apart from this, what we get is the immune effector cells, so the CNS side effects. HLH like or macrophage activating syndrome like condition is very rare. We don't see very much. We do get a little bit of DIC. Patients become hypogammaglobulinemic, and some of them would need replacement IVIG for quite a long time. tumor lysis is rarely seen, but it's something, again, you're thinking of a high disease burden, a very aggressive tumor, you have to keep that in mind. The late phase, one of the most kind of uh, things which they are scared of is persistent cytopenias and hypogammaglobulinemias. T cells go on to kill the cancer, so your T cells don't have the intelligence enough to kill other infections. So those are things that happen. So we need to keep in mind of all these things. So these are the guidelines for the grading. This is the ASTCT guidelines. I will just skip through this, and we will come and talk a little bit about the BCMA cars, which we have got. So as I said, BCMA is specifically expressed on plasma cells and myeloma cells. It is also expressed on some epithelial cells. The corneal epithelium has a little bit of more BCMA compared to other epithelial surfaces. It belongs to the TNF alpha superfamily. Generally not expressed in other tissues, more in the plasma cells. It is important for the transformation of B cells into plasma cells. And there is also a soluble, this BCMA is cleaved from the surface by the gamma secretase. So you get the soluble BCMA in the serum. And that can be also used as a biomarker. So that is something which people are thinking of using biomarker for a relapse. So what we have got against BCMA are this is the belantamab, which is an antibody drug conjugate. We have got some bispecific antibodies which is still in trial. We are going to get a trial with teclistamab, which is a Johnson Johnson product. There is an Amgen product which is coming in AMG 701. Another Amgen product has been taken off, which is 401. So these are again things that you can think of will work very much like a CAR T, will bring the T cells. But one of the things in multiple myeloma is that the relapse happened because of T cell dysfunction. So when we seeing the activity of T cells in a normal in a de novo myeloma patient presenting to us at the very beginning, compared to relapsed refractory myeloma, we see that T cell activity in a RR myeloma is definitely much less. So the question that is going to happen is, how are we going to get those T cells to work against the myeloma by giving them bispecific antibodies? Is there a way of activating those T cells? One way is by giving daratumumab. Daratumumab activates your cytotoxic T cells. So you give daratumumab first and then give the bispecific antibody. The other way is that my T regulatory cells go up. So is there a way of decreasing the T regulatory cells? So one way is by giving lenalidomide, which is going to kill your T regulatory cells quite a bit, and then give the bispecific antibody. So these are things that people are trying in trial, and this is an evolving field, and we will get knowledge. So we are in our hospital, we are also starting some of these trials. Again, these are company sponsored trials because this is a drug which we won't get otherwise. The CAR T cells, so the ide-cel and the cita-cel, the first two have been FDA approved. And let's just have a look at that. So this is my ide-cel and cita-cel. Again, there are many trials which have come out with that, and the first one with ide-cel was Karma, and we can see that these are basically greater than 3 lines, greater than 4 lines treated patients, and we are getting kind of good response with that. And this is almost going up to 32 months here. So this is progression-free survival, and this is overall survival. But even better data is from the CARTITUDE trials. So we had a seminar on cellular therapy in the month of May. And next time, definitely it will be very good for you people also to join, either virtually, or if you can come to Calcutta, we'll be really delighted. But we had a lady called Deepu Madhuri who was in the CARTITUDE trial giving us a talk on this. And I think the CARTITUDE, the Johnson & Johnson's the cita-cel has got 2 domains against BCMA compared to ide-cel. And I feel that, even at a lower dose, we are getting a very good response with cita-cel here. So definitely, if you're going to think about a BCMA CAR, which is now in market, Citacel is something to think about. But we don't have that. So what are we doing in India? So what has happened is, if you know, there is a place called Origin, Aurigene, and at Bangalore, where the headquarters of HCG is also there. That is the research arm for Dr. Reddy's laboratories. So Origin and us at Kolkata, we have signed up for a phase 1 trial for using a car with, again, two domains like the CETA cell, but this is going to be not the Johnson Johnson car. The vector is going to be different. So we'll have to start from a phase 1 trial. So hopefully, later this year or early next year, we're going to get this trial into motion. So so as I said, that CAR T cell, obviously we know that CAR T cell is working for lymphoma. We haven't talked very much about that. I focused mainly on CAR T cell in myeloma. As I said, that this is an unmet need. In lymphoma, what I feel is that we can get away by doing autologous transplant in the majority of patients. In the relapsed refractory myeloma setting, when a patient has had daratumumab, had carfilzomib, and there is very little that you can do, rather than wasting the patients with further things, you would rather go on to a CAR T cell therapy. There are further CAR T2 trials happening with CAR T cell early in treatment, and even now they are doing it upfront. So upfront for normal patients and upfront for high risk patients. So those are things, those are data we are waiting for to see how it comes out. But I think CAR T cells in myeloma is going to play a significant role. The major reason being that the patients here will be, the patients that we're going to get here are going to be quite infirm, elderly, who will most probably not be able to go into the toxicity of a tandem autologous or an auto allo transplant. So maybe this is the best form of immunotherapy in multiple myeloma. And in so before coming to that, in definitely in a relapsed refractory lymphoblastic leukemia. So and this is especially important for the kids. So I don't know whether I've got slides for it. I'll see, but let's just talk a little bit about ALL and CAR T cell therapy. So, the world was taken aback when this girl from Great Ormond Street in London was treated, and she's still in remission from a relapsed refractory acute lymphoblastic leukemia. That was the first publicized event for CAR T cell. So ALL is definitely a place where we have to think about some kind of immunotherapy. And one of the safer ways of doing this is doing a CAR T cell therapy. Again, commercially, a CD19 CAR is available. We are trying to develop a dual CAR, a 19 and a 22 CAR for ALL patients. So let's see how that goes. But again, that is one of the major indications of CAR T cell therapy is acute lymphoblastic leukemia. Let's see what can we do about this chap. So this is a 10-year-old boy with relapsed acute myeloid leukemia. He's a big chap. It's more than 45 kgs. We didn't feel a cord transplant is going to work for him. So the major thing that we do, or any centers, any hematology centers will do, is to give induction chemotherapy, 1 or 2 cycles, allogeneic transplant. Now, what induction chemotherapy you give, how you take the boy towards an allogeneic transplant, let's not talk about that. But we do an allogeneic transplant because what we want is we want this graft versus leukemia effect, where all these cells are going to work and kill the cancer cell. But for that, we need a match. And, so we get half from the mother and half from the father. So we always a haploidentical or a half match between the parents and us and between our children. So the question that used to come to us is there any way that we can differentiate between the harmful T lymphocytes, which give rise to lots of graft versus host disease, and the graft versus leukemia effect? Is there any way we can do it? And we can do it or we can try to do it. I would not say we can do it in our specialty especially, we can try or we can attempt to do it with this machine, which is called the Clinimax machine. So what it does is that it takes away the alpha and the beta T cells away with the help of an electromagnetic separation, and keep the gamma and delta T cells intact, keep the NK cells intact. So I'm not pan T cell depleting. Remember that. I'm not pan T cell depleting this. Just excuse me a minute. একটা meeting আছে একটু পরে করি. So we're not pan T cell depleting this. We're just taking the good cells. So if you say the gamma delta T cells are the good cells, that is what we are trying to do. The other advantage of this is what we can do is we can take some CD45. We can deplete the CD45 RA and keep the CD45 RO cells. We take away the naive T cells, keep some of the memory T cells, and keep that as a DLI infusion. So in this transplant, you can see what we can do is we are partially T cell depleting the graft. We are taking the memory T cell infusion, MDLI infusion, keeping it, storing it. And when the patient is relapsing, as I said, I have got a young girl whose chimerism had fallen down. I am giving that MDLI back. With that, my chances of graft versus host disease, as with all DLIs, is less. And I still get good effects. This was a very interesting case. This was a BSF employee. It is a border security. It's one of the defense organizations in India who came to us with a cancer, and we were able to bring him to remission. We did a haploidentical transplant with the Clinimax, and then on day plus 14 he had COVID-19. This was this year January, and we were struggling. What do we do? But thankfully what we had was we had those T lymphocytes with us, the MDLI with us, and we gave it back to him. Though he had a little bit of lung infiltration, needing oxygen for a few days, he did well after that. So I don't know whether he would have done well without it or not. At least we had those T cells to give it to the patient. And this becomes very important when patients start suffering from other infections also. For example, if you have a high CMV and your marrow is absolutely stressed out, and you can't give too much ganciclovir there, what can you do at that point? So this is where this cells also help. We can specifically prepare anti-CMV T cells, but along with that, that will takes time. If we have this in hand, we can give it directly. So be it any viral infection, we have used it in COVID also. So I think that is one of the cases which should have been written down, but my fellows are not very enthusiastic about it, I feel. So if you want to write it, any of your students here, we will give you the data. We will do a collaboration. But I'm getting a bit frustrated with all. There's so many papers to write in one hematology department. If you work, you will get at least 7 papers a week to write. But anyway, so with this patient, we gave 2 doses of DLI. We also gave some mesenchymal stromal cells or stem cells, and the patient has done well with that. So the other thing with that machine we can do is we can do what we call NK cell therapy. Now, natural killer cell therapy has already been talked about in the form of giving NK cell infusion during haploidentical transplant. This was mainly in the pre-Clinimax era or pre-cyclophosphamide era also, where we used to do a pan T cell depletion, but we used to get the natural killer cells out and give an infusion. So hopefully that is going to prevent the diseases that happens just post-transplant, and also prevent a relapse. But you can try to use all this with that machine and do it. And we've tried just giving NK cell infusion as such. So what we do is we are doing it on a basis of a clinical trial. You are lymphodepleting the patient, and then you are extracting a haplo NK cells, and you are infusing the haplo NK cells. And we have done 2 patients with that so far. One with a CML blast crisis who passed away. The other, we did it in a patient who is the astrologer of the Chief Minister of West Bengal. So if you know our Chief Minister, you would No, she also has a formidable astrologer. And that man had acute myeloid leukemia at the age of 72 or 73 years. And that has worked very well. So, it is a hit and go, but this is something again which we can give to our patients or offer to our patients, but again on the basis of a clinical trial. As I said, we can manufacture the antiviral T cells. One of the most interesting things, let me just talk a little bit more about the NK cells. So this NK cells, is something, if I find them something of an enigma, because they are going to be present during the transplant. They are so very important post transplant. You know what we do in our transplant? We give all our donors plexifer, and then we give it 4 hours before. And what we are seeing is that my NK cell bright population is increasing almost 2 or 3 folds after we do that. And the NK cell bright population and the plasmacytic dendritic cell population, which increases, is supposed to prevent the grade 3 or grade 4 graft versus host disease, yet keep the graft versus leukemia in place. So, these are some of the ways we are trying to differentiate between GVL and GVHD. And people have gone a step ahead of us. And what they are now trying to do, my ex-colleague at Hammersmith, who is now at MD Anderson, Katie has opened a lab, and Katie has been training lots of people all around the world. There's a girl called Francesca at Singapore. There's a girl who has gone to Malaysia. So she has been training people all around the world to do NK cell CAR. Okay, so the NK cells, what they're doing is they were isolating this from umbilical cord. So your chances of graft versus host disease is less. And as I talked about the CAR T cells, so your CAR T is not on a T cell but on an NK cell. So the NK cell is obviously going to give rise to more cytotoxicity. It is going to identify that cancer cell and kill it. There are certain issues about NK cell CAR, and one of the major issue is the longevity of the NK cell CAR. So the last meeting we had, one of the major or one of the suggestions that we have been able to give to those researchers is that we use the NK cell CAR as the off-the-shelf product, because it is NK cell beyond the HLA barrier. It is not going to give rise to GVHD. So you can use NK cell CAR and keep it on the shelf and use it when a patient, let's say, or with lymphoma, with AML comes, and use it as a treatment for induction or reinduction of that patient. And then once the patient is a little bit better, you can then think of using a T cell CAR, which will have a better longevity. But efforts are being tried to increase the lifespan of the NK cell CAR also, to make it more efficacious. You give them azacitidine, your antigens go up, and your NK cells will look into that and kill it off. So all these things people are trying to do. And as I said, with Origin, the second trial that we are starting is on a indigenous based lentivirus based NK cell CAR. So let's see how that goes. That might be again, middle of next year, but we have started working on it, and we will have these two trials definitely. One is a BCMA, the other is the NK cell CAR. So the question is, so this is what I told you, that we've used it into the NK cell thing into. So the question is that what happens to our patient who now needs a CAR T cell therapy? So unfortunately, everything is in a clinical trial till we have the proper results out of the trial. So for now, what we are doing is that we are collecting the cells. Each and individual cells a patient would need a special approval from the government. The cell then goes away to another country where where the cell is manipulated, the CAR is made, given back to us, and we infuse it. That way, the cost has come down to almost 1/3 the cost of what the commercial CAR T cell would have emptied our pocket with. Okay, so that's all I have.
So thank you very much. It's very comprehensive and cover many areas. Um, we are very much interested in CAR T therapy, but we thought initially it is too expensive and there will be nothing to do with us. But now we have a lot of hope, and probably some of our patients might get beneficial from this kind of treatment by going to a center or neighboring countries. Even in Singapore, it is still extremely
It's
expensive.
very expensive at Singapore. So Singapore is perhaps the place in India where the commercial CAR T is available.
Yeah.
And it is so expensive that hardly, well, I would say 1 or 2% of the population will be able to afford it.
So, but in your center,
Hmm.
what I understand is the two trials are going on, PCMA CAR and this NK CAR.
No, there are
NK
some other trials happening with CD19 CAR, but I
Right.
didn't mention because CD19 CAR trials have started in many places in India.
Yes. Yeah.
So we are doing a CD19 phase 3 trial with TMH in Mumbai,
Right.
and we are doing a CD19 lentivirus being developed in India with Reliance Biosciences. So that is starting from a phase 1 trial.
Right.
But I mentioned mainly on the BCMA and the NK CAR because nobody else is doing it at this point. And I think the NK cell CAR is something we really need to think of because this is going to be an off-the-shelf product. And patients whom we haven't got anything else to treat with, or if we are going to give something with which they're going to die, let's say at ALL, and we're going to think of hyper-CVAD, and the patient is going to die of neutropenic sepsis because of that. I think those are cases where my NK cell CAR is going to come very, very handy. It is going to be much cheaper if it's because it's an allogeneic CAR, number one. And number two is, I don't have to wait for the 3-4 weeks for the CAR to come back to me.
Mhm. So, but for that trial, you were recruiting all sorts of.
We haven't recruited any foreign patients for that. We will have to look into it, how we can put patients from foreign nationals in those trials because those trials have been DCGI approved. Best would be for your patient to get married to some Indian people there. And then we can.
So, but BCMA CAR is affordable, available for overseas patients?
It can be. It can be. So BCMA card definitely is available for overseas patient. Maybe not in the trial basis, but we can definitely make it available in this basis.
And CD19 CAR,
Absolutely.
that is commercially available?
Still, we can make it available. You see,
Yeah.
we can definitely make it available. Each and every patient needs a special permission from the government of India.
For any CAR T
For any country. So that there are mechanism in place to get that done. So I don't think that will be too much of an issue.
But that CD19 CAR is in collaboration with TMC Mumbai.
TMH
TMH
Mumbai.
Yeah, right. Here, some of my candidates, my juniors, are trained in TMH.
All right. Okay.
And she also returned from TMH 2 years back.
All right.
So
Naveen was
Yes.
Naveen went to UK when I was there.
Right.
So we then got him into with David Marks and in Bristol.
Yes.
So yeah,
He was in UK for 13 years.
I was there for
Right.
13-14 years there.
I see. And I saw from your CV that you work in St. Barth.
Yeah, Baths and Hammersmith. You were there at Baths?
No, but I work in Homerton.
All right.
Because I want to learn some sickle cell.
All right.
So,
Okay.
but I used to work in, I mean, not for a long time because we have only 3 years leave from our country. So after crossing MRCP, I worked in King's and also UCL.
Prof Al Ho is at Singapore now.
Yes, yeah.
So
Yes, he was in King's before I went there. Anyway, so we have, in fact, we did have one refractory ALL, which we use Blindside to, but we are very shortage of drug supply, and we tried to get some drug from Amgen, but we could not manage to get in time. He was a nurse, and people try to support him. And with this charity funding, we try to treat him. Um, but we are hoping that the car might be helpful for him. But unfortunately, sadly, he passed away last week because we have no other options to control his count, and we have run out of this plancite dose. So in the meantime, while waiting for the drugs, we use fludarabine, and we, after 2 years of disease, he developed sleep time.
So from my side, what I can say is that please, you've got my email. Mr. Singh is here. We are always available if you want a quick chat with us. Whatever we can give you options now. Whether that is going to be applicable to this place or not is a different question. But I can definitely help you out. If you have any fellows who want to come to see what we are doing or learn, I am more than happy. And as I said, if those fellows come and write some papers for me, I will be elated.
I'm also hoping that they can produce a paper, but at the moment, I can push them, I can force them. Anyway,
And we can work for collaboration, like if you have some students or some fellow, they can go for 6 month, 3 month training.
Absolutely.
It will be a very good
Absolutely.
for us.
good news.
Yeah. So like just going to this Tata Memorial Hospital, you can go to Calcutta also. Calcutta is very near to go. Now from October we will going to have a daily flight,
Yes.
and it is that air ticket is also cheaper.
She hasn't been to abroad, the others have already some experience exposures. Anyway, we have several leukemia patients, so
Yeah.
we hope that the CD19 for selected cases might be possible.
Absolutely.
Right.
Absolutely.
Yeah.
The
only
question
thing
that
is-
happens is that the post or if you